Ladies and gentlemen, please stand by. The conference will begin momentarily. We thank you for your patience, and we ask that you please remain on the line. As a reminder, today's call will be recorded Tuesday, March 27th, 2018, for training and review purposes only. We thank you for your patience, and we ask that you please remain on the line.
Good afternoon and welcome to Quorum CVS Clinical Webinar Series. My name is Joyce Grant. I manage the Quorum CVS Continuing Education Department. Today's program topic is current trends in chronic heart failure. Quorum CVS Specialty Infusion Services is proud to offer this opportunity to clinicians to participate in continuing education presentations from nationally known speakers. To cover a few housekeeping items, today's program is approved for case managers, registered dietitians, as well as registered nurses. Those who wish to receive 1 CE credit hour for participation in today's program will be asked to complete the post-event evaluation. If you are attending in a group or via teleconference only, please forward an email to the CE department at cedept@quorumhc.com and request a webinar evaluation for today's program. Please note you will be required to provide your license number to receive a post-event CE certificate. Please note that the planners and presenters of this educational activity have signed conflict of interest disclosure statements. Any disclosed influence and financial relationships have been resolved, and no commercial support has influenced the design or the scientific objectivity of this educational activity. In addition, commercially supplied funds were not received for this event. Quorum CVS accredited status does not imply endorsement by Quorum CVS of any commercial product in conjunction with this activity. You will be informed if any of the products referred to during this activity are used for off-label purposes. Today's program will last approximately 50 minutes. We will then open the lines for a question and answer period with our featured speaker. Before we begin, I would like to take a moment to welcome and introduce Michelle Phillips. Michelle has been a registered nurse for over 9 years. Currently, she is an RN supervisor for Quorum CVS Specialty Infusion Services. Her previous clinical background includes primary nurse care, case manager for Quorum CVS Specialty Infusion Services, and a post-anesthetic care and pediatric intensive care. We want to thank you all for joining us today, and I will now turn it over to Michelle to begin today's program.
Thank you, Joyce, and thank you everyone for joining. I'm going to start off by going over the objectives for the course. So number one, we're going to discuss the advanced pathophysiology of heart failure. This section will discuss how the other major symptoms are affected, as well as define systolic versus diastolic failure. Number two, depict the differences in diastolic heart failure versus systolic heart failure. Diastolic heart failure, more commonly called heart failure with preserved ejection fraction, is now being recognized as vastly different than systolic or heart failure with reduced ejection fraction. A review of the current literature on diastolic failure will be discussed. Number three, describe the current treatment options from the American Heart Association and the American College of Cardiology and the New York Heart Association classification system. Number four, discuss palliative management issues surrounding heart failure. Many heart failure patients have aggressive treatment options available, such as transplant or ventricular assistive devices. However, the majority will require some palliative care throughout the process and at the end of life. Number five, discuss home management options for heart failure. Because of the cost of heart failure is increasing, it is ever important to be vigilant about the site where heart failure is treated. Whole options will be described. General statistics. So why is heart failure so important? Heart failure is a diagnosis receiving a lot of attention in terms of ways to understand the complexity of the disease process, to consider best ways to prevent, treat, and support in the most cost-effective manner. Trends are predicted to rise. The American Heart Association predicts that the number of heart failure cases will increase by about 46% by 2030 to greater than 8 million people in the U.S. That's 1 in every 33. If one assumes all costs of cardiac care for heart failure patients are attributable to heart failure, no cost attribution to comorbid conditions, the 2030 projected cost estimates of treating patients with heart failure will be threefold higher than today, which is $160 billion in direct costs. Again, this slide reinforces the impact. There are currently nearly 6 million patients diagnosed with heart failure in the U.S., with an additional 650,000 new cases diagnosed each year. Heart failure is a significant contributor to mortality. As you can see here, 1 in 9 deaths have heart failure listed on the death certificate. Heart failure is the most frequent cause of hospitalization for people aged 65 and older and has a 5-year mortality of about 50%. In fact, once patients have advanced to a stage requiring a first hospitalization, life expectancy is only about 18 months. Heart failure is primarily a syndrome of the elderly, with a significant risk for both men and women by age 40. Important, too, is the ethnic component. As many as 1 in 100 African American men and women develop heart failure before the age of 50. That is 20 times the rate in whites in this age group. In fact, in a study by the National Heart, Lung, and Blood Institute of National Institutes of Heart Failure, Health Heart Failure, developed in Black participants at the average age of 39, significant factors include high blood pressure, obesity, and chronic kidney disease 10 to 20 years earlier. But, as we will discuss later, there is also another specific physiologic reason for the increased incidence and younger age onset. Again, looking at the impact on healthcare system, heart failure, a primary diagnosis and over 1 million hospitalizations each year, requires significant resource utilization and ultimately costs our healthcare system over $40 billion annually. Half of that is on hospitalizations. Any impact on cost will make a difference. Causes here. Here are some key examples. This list is not all-inclusive, as there are many different contributors to heart failure. These are just some of the most common ones. The cardinal manifestations of heart failure are, number 1, dyspnea and fatigue, which can lead to exercise intolerance. Number 2, fluid retention, which may lead to pulmonary and/or sphenic congestion and or peripheral edema. However, it is important to remember that some manifestations can present and not others. For example, some patients have exercise intolerance but little evidence of fluid retention, while others present predominantly with edema, dyspnea, or fatigue. Since all patients do not present with signs and symptoms of fluid overload, the term chronic heart failure is preferred over congestive heart failure. Okay, so now we're on to pathophysiology. It's important to recognize that heart failure is a complex clinical syndrome, not a disease. Heart failure is the result of the body's responses to an underlying disease that results from a structural or functional cardiac disorder that impairs the ability of the ventricle to fill or eject blood. When injured or stressed, the body responds with a series of hemodynamic, neural, immune, and hormonal responses that help compensate for whatever the injury was. Over time, those compensatory mechanisms can be damaging, as we will be reviewing throughout this program. The most recent AHA guidelines recommend getting away from the terms right-sided diastolic and left-sided systolic heart failure, and use the terms heart failure with preserved ejection fraction and heart failure with reduced ejection fraction. The main causes of heart failure still continue to be coronary artery disease, hypertension, valvular disease, and dilated cardiomyopathy. Any form of heart disease may ultimately lead to heart failure syndrome. So, in other words, CHF is not a result of a defective pump. It is the persistent overactivation of various compensatory systems of hormones. By interfering with this compensatory hormonal response, we can slow the progression of left ventricle remodeling. Here's a poll question to give us something to think about. Joyce, can you open up the poll for us? It's going to give us 1 minute to answer this question. So, looking at this diagram, how do you think we can interfere with the hormonal response? Look at your choices A, B, C, and D, and choose your poll. Once we get some results, we'll discuss what the answer is. All right, it looks like everybody did fairly well. So the answer is D, all of the above. All of these therapies listed are going to help out with with interfering the hormonal response. Before we get into the terms listed here, ejection fraction compares the amount of blood in the heart to the amount of blood leaving the heart each time it contracts. So the lower the ejection fraction, the more progressed the heart failure. An EF of 50 to 70% would indicate normal pumping ability, whereas an EF 41 to 49% is considered borderline. An EF of 40% or lower is considered low pumping ability. To make it simple, the box on the left are terms describing a heart that cannot contract well or has trouble pumping blood out of the left ventricle. The box on the right are terms that describe a filling issue. The left ventricle cannot relax properly, so therefore does not fill properly. These issues lead to cardiac remodeling, which is basically a change in the geometry and structure of the left ventricle. The change is that the chamber dilates and or hypertrophies and becomes more spherical. This change in chamber size and structure not only increases the hemodynamic stresses on the wall, but also increase regurgitant flow into the mitral valve. the heart eventually gets more spherical and just cannot contract as well to empty. An important point to note is that cardiac remodeling generally precedes the development of symptoms by months or even years, continues after the appearance of symptoms, and contributes substantially to the worsening of symptoms despite treatment. As I said a few minutes ago, the major determinant of the progression of CHF is the persistent overactivation of various compensatory systems of hormones. Even if the initial injury is stopped or slowed, these changes lead to neuroendocrine activation, specifically the sympathetic nervous system and the renin-angiotensin-aldosterone system. These systems activate neurohormones, which by nature are important and useful in short term, example like fight or flight response. However, with prolonged exposure to these neurohormones, damage to many systems ensues. So this is the cycle that we have displayed here. It essentially starts with a decreased cardiac output. When cardiac output is low, the other organs in the body have a decreased blood flow. As a result, the sympathetic nervous system is activated to increase contractility and blood flow. This leads to vasoconstriction and will also cause the kidneys to assume that we need more blood pressure, so they produce the renin. Renin produces angiotensin 1, which converts to angiotensin 2. Remember the earlier slide that discussed how the various medication blockers interfered with this process? This is why. So left uninterrupted, angiotensin 2 causes vasoconstriction. As we said, the result is elevated blood pressure, although again, it was not low blood pressure that was the problem. Angiotensin 2 leads to the production of aldosterone, which causes salt and water retention, which leads to increased cardiac filling pressures, so the heart's working even harder. The end result of the hormonal activation and the increased pressures of the heart will lead to hypertrophy and cardiac left ventricle remodeling, systolic heart failure, or heart failure reduced ejection fraction. It is a cycle that will continue unless it's interrupted. While we are using the terms systolic and diastolic less, this is a great image and description for heart failure with preserved EF, diastolic and right-sided, as compared to heart failure with reduced EF, formerly systolic or left-sided. Instead of due to left ventricular failure and the resulting decreased ability to pump blood out in diastolic failure, cardiac output is limited by abnormal filling of the heart chambers. So some prognostic indicators. Let's look at some of the factors that help predict outcome. Patients with these factors on the slide tend to have a poorer prognosis. So older age, gender, race, classification, the greater the symptoms impact the ADLs, the less likely sustained survival. The ejection fraction being less than 30% is very significant, and comorbidities listed here. All of these will decrease the prognosis. The presence of remodeling can be seen on an echo. A larger heart, rounder hypertrophy, as we discussed. Exercise capacity. Exercise intolerance can be the first real symptom the patient has. Any arrhythmias? And lab values. Lab values can relay how well the heart is pumping. And we'll get to that a little bit later. Moving into diagnosis. The most essential diagnostic tool is the two-dimensional echocardiogram with Doppler. This echo identifies both what chambers and valves are affected, as well as any structural changes. It also measures ejection fraction and can therefore provide a baseline. A radionuclide ventriculography or an MRI may also be used to provide information regarding the nature of the severity of the disease. We can also look at BNPs. BNPs are synthesized by and released from the heart in response to stretching of the muscle fibers, reflecting wall stress, increased load. Clinicians have looked at BNP levels to diagnose the presence and degree of fluid overload. Most currently, however, BNP levels are recognized as a reflective of stress on the cardiac muscle wall. Levels are increased with hypertrophy remodeling. BNP levels are used for diagnosis of heart failure, but are more importantly one of the strongest predictors of prognosis. BNP level after treatment is more significant for prognosis than the baseline. Elevated BNP levels are seen with reduced ejection fraction. Elevated levels tend to support a diagnosis of abnormal ventricular function or hemodynamics causing symptomatic heart failure, although it is important to rule out other causes of dyspnea as well. BNPs tend to be lower in obese people. Levels may also be meaningfully elevated in women and in people over 60 years who do not have heart failure. Thus, BNP levels should be interpreted cautiously in these individuals when distinguishing between cardiac and non-cardiac causes of dyspnea. There are two heart failure classification systems, the American College of Cardiologists, American Heart Association, and the New York Heart Association. This slide illustrates the differences between the two systems. It is interesting to note that the ACC-AHA system, Stage A, are essentially people with risk factors and no structural damage. The NYHA classification is more symptom-based. Classification of a patient may determine whether or not Medicare will cover some of the more advanced treatments. So these systems are important to be aware of. Okay, so moving on to treatment. Treatment can be broadly classified as non-pharmacologic and pharmacologic. We will discuss them in detail further on. Obviously, the reduction of risk factors has a major impact on the treatment of heart failure. These include dietary changes, smoking cessation, exercise, weight loss, reduction of alcohol consumption, and management of hyperlipidemia. Nutrition, your oral diet, and sodium restriction. Sodium is a critical issue for patients with heart failure. A high sodium intake can cause fluid retention and therefore contribute to edema. Fluid accumulation puts a strain on the heart and could lead to shortness of breath. Sodium intake should be less than 2 grams a day. Fluids. In advanced cases of heart failure, fluid restriction may be ordered to reduce the stress on the heart. Cholesterol. High blood cholesterol levels have been linked to a coronary artery disease, the leading cause of heart failure. A diet high in saturated fat leads to high-level LDLs, or quote-unquote your bad cholesterol. Other nutrients. Potassium and magnesium are important minerals in the diet. Diuretics used to get rid of excess fluid may deplete your body of these nutrients. Cardiac cachexia. is a common complication of CHF, which is associated with poor prognosis. Patients with cardiac cachexia suffer from generalized loss of lean tissue, fat tissue, as well as bone tissue. Cachectic CHF patients are weaker and fatigue earlier. Consideration of nocturnal supplement tube feedings are sometimes indicated to support patient needs and prevent malnutrition. In rare cases, parenteral nutrition can be successfully used to support nutrition needs. For heart failure patients, tube feeding and parenteral nutrition volume, they generally need to be minimized and concentration of nutrients occurs to provide optimal support. In most cases, these tube feedings and parenteral nutritions are initiated in the hospital. These therapies can be safely administered at home to support the patient's needs. Ultrafiltration. One of the newer treatments you may see is ultrafiltration. This is a process that looks like dialysis, but it's done to remove water only, not waste products. The average amount of fluid removed is 250 mils per hour, although higher amounts may be possible. While it is not dialysis, it is recommended that nephrology be involved and research continue in this area. Cardiac transplantation. This is currently the only established surgical approach to the treatment of refractory heart failure. However, it is available to less than 2,500 patients in the U.S. due to organ donor shortage. Heart transplantation is an option when other treatment options have failed and the patient has a life expectancy without a transplant of less than a year. Some patients will be supported until transplant with such devices such as an LVAD or with inotropic therapy. The good news is that the survival rates are good. Ventricular assist devices. These implantable pumps were once just used as a bridge to transplant, but now they have become so effective that doctors may use them as a permanent treatment. Patients with advanced heart failure with an LVAD typically live longer and experience improved exercise tolerance and quality of life. They do pose an increased risk of stroke and an increased risk of infection. Some people with LVADs need to take anticoagulants to lower the odds of stroke. ICD. An ICD is an implantable defibrillator used, 1, when patients are at risk for sudden death due to ventricular arrhythmias, or 2, have chronic heart failure and a low ejection fraction who experience syncope of unclear origin. When the device detects an erratic rhythm, they deliver a shock to stop the rhythm. These devices may also have pacing abilities to keep the heart rate up should the rate become too low. ICDs are used in conjunction with continuous inotrope therapy. Cardiac resynchronization therapy. It's also known as biventricular pacing. It keeps the heart beating at normal rhythm. It's not recommended for patients with right bundle branch blocks. It may be used alone or in combination with an ICD and has resulted in significant improvements in quality of life, functional class, exercise capacity, and survival. Cardiac remodeling. On the left, the cardiac splint. These splints are placed to pull the heart into a correct shape. The right ventricular jacket reshapes the heart for improved function. However, this was never FDA approved, so production has stopped. So now we're going to move on to pharmacological interventions. This diagram essentially puts it all together, and you can see where certain medications work and therefore why they are used. Remember earlier when I pointed out that the 4 pharmacological interventions were focused on interfering with the hormonal cascade? This image shows how they stop the progression towards ventricular hypertrophy. ACE inhibitors. This is the first line of therapy in all classes of failure. It blocks the neurohormonal activation, prevents conversion of the angiotensin 1 to angiotensin 2, decreases degradation of bradykinin, promotes vasodilation in the vascular endothelium. They slow the progression of heart failure and decrease symptoms, hospitalizations, and mortality. Angiotensin receptor blockers. If the patient cannot tolerate the ACE inhibitors, they may be prescribed angiotensin receptor blockers. While these drugs don't stop the conversion to angiotensin 2, they do block the ability of angiotensin 2 to work. The newest class of heart failure drug is a combination angiotensin 2 receptor blocker, neprilysin inhibitor, which inhibits both renin, angiotensin, aldosterone, and neprilysin. Neprilysin is what will increase the natriuretic peptides. Beta blockers. Another first-line therapy drug are beta blockers. Used with ACE inhibitors or ARBs, beta blockers counteract the harmful effects of the sympathetic nervous system that are activated during heart failure. Beta blockers should be initiated at very low doses, followed by gradual increments in dose as tolerated. Beta blockers may need to be discontinued during acute decompensation, but need to be resumed prior to discharge. Diuretics. Most patients are prescribed diuretics to promote sodium and fluid excretion. Loop diuretics are most commonly used, but patients with hypertension may benefit most from thiazide diuretics due to the more persistent hypertensive effects. Electrolyte imbalances are common with diuretic use, so close monitoring is essential. The guidelines for potassium levels are to be maintained between 4 and 5. Importantly, a balance of ACE1 with diuretics is necessary, as diuretics usually stimulate the renin-angiotensin-aldosterone system. Aldosterone antagonists may be used as diuretics as well. They may be prescribed in combination with or instead of other diuretics themselves. It is important, however, that patients have good renal function. The creatinine should be less than 2 and a stable potassium less than 5. Nitrates. Nitrates are used to promote vasodilation and decrease blood pressure. They may be used acutely to treat angina as well. Treatment by race. Remember what we said earlier about the reality of physiologic differences in the African American population. These patients naturally produce less nitric oxide, the antioxidant that protects the heart from stress and aging. Thus, Bidil is one of the first vasodilator agents reported to be useful for CHF, as it enhances the bioavailability of the nitric oxide they do have. Vasodilators. Natractor is a recombinant BNP that acts as a vasodilator. It works by binding to certain receptors at the veins and arteries and allowing them to relax, causing better blood flow for the heart. Natractor is used to improve breathing in people with CHF. It is indicated for IV treatment of patients with acutely decompensated CHF who have dyspnea at rest or with minimal activity. Digoxin. Digoxin's interesting. It is certainly a drug long associated with CHF treatment. However, digoxin has actually been removed from a Class 1 recommendation, meaning good scientific evidence to support use of a drug, to a Class 2A, meaning usefulness is not well established by scientific evidence, primarily because it was not shown not to slow the progression of the heart disease or prolong survival, although it does decrease hospitalizations. Thus, current guidelines suggest therapy with digoxin only in patients who continue to experience signs and symptoms while receiving optimal medical treatment, including ACE inhibitors and beta blockers, and to discontinue if there is no impact on congestion or if the patient becomes too hypotensive. However, that is being challenged, especially in certain high-risk groups. Inotropic agents. Most common, dopamine, dobutamine, milrinone. Increased cardiac contractility, vasodilation. They're a bridge to transplantation or palliative care. The research on inotrope agents has shown efficacy. However, mortality is higher in these patients due to sudden death secondary to ventricular arrhythmias. For this reason, it is recommended that patients on continuous inotropes also have an ICD. There are several inotropic agents. These three are used most commonly. While they all act in different ways, the end result is increased cardiac output. Milrinone does a distinct advantage for home use, and that is its longer half-life. Dobutamine and dopamine, the half-life is 2.5 minutes, or roughly about 2.5 minutes, where milrinone, the half-life is about 2.5 hours. Most physicians stop beta blockers when using dopamine or dobutamine due to competing actions, and therefore some believe that milrinone confers an advantage in heart failure management, as beta blockers can still be used mitigating heart failure symptoms. We are seeing more and more inotrope use in the home. Patients can now be treated in the home without losing their status on the list. Medicare is no longer approving most outpatient clinic intermittent use, therefore is not reimbursing outpatient clinics. As the value of palliative care and the improvement in quality of life that is often experienced when patients are administered inotropes are increasingly recognized, use is going up. Home inotropic therapy increasing due to more cost-effective delivery model versus the hospital. It's covered by Medicare Part B. It's strict criteria, but it can be covered. May help address Medicare readmission concerns, decrease nosocomial infection risk, quality of life, and safety concerns include risk for fatal arrhythmias, However, most patients now have ICDs in place or are DNRs, so all patients should receive 2 pumps. So one is available for backup if the patient's on continuous therapy. Opioids. Pain management is also an important, often underappreciated option in the treatment of CHF for several reasons. In addition to helping with the pain of angina, diabetic neuropathy, etc., opioids help with vasodilation. They decrease the patient's awareness of dyspnea and the need for O2 consumption. Morphine may even help stabilize end-stage CHF. Palliative care focus. Palliative care is all about symptom management and is thus important throughout a patient's illness continuum. It is about quality of life and facilitating whatever therapies and interventions that support that quality of life. I'm not going to spend too much time on these next several slides, but incorporate them. One, to recognize that symptom exacerbation is a primary impetus for readmission to the hospital for patients with advanced CHF, and ways to minimize unnecessary rehospitalization that can be addressed. And number 2, to illustrate the multidisciplinary and varied interventions that can support symptom management and decrease symptom burden. Fatigue is reported in over 50% of CHF patients. First strategy in management is to determine if the patient may have an underlying sleep disorder. If determined, CPAP therapy may be initiated. Other suggestions are supplemental O2, exercise to improve stamina, and possible psychostimulants. Anxiety. If an anxiety attack would occur at home or away from care, an emergency kit can be formulated with medication, music, etc. to help settle the patient. % of patients deal with depression. It's important to point out that antidepressants, the SSRIs, cause hyponatremia. So keep that in mind with management of your cardiacs. Pain, we've discussed. 50% of patients are going to have pain. You want to avoid NSAIDs and use opioids. Physical therapy can help as well. Alternate site care. So as we talked about, the cost of care for CHF are extremely high. In order to promote cost-effective care while ensuring positive patient outcomes, careful consideration of appropriate site of care is essential. Skilled nursing facilities are an option for patients that meet criteria. Home health care has become increasingly popular. It's no longer seen as just going home to finish therapy, or the visiting nurse will follow up with the patient. Home health care options are now an extension of care. High-tech, high-touch care, education, management of the care plan, assessment, and skilled care, infusions of wounds, etc., can occur safely in the home. Durable medical equipment can be provided in the home to make activity safer. Oxygen falls into this category. Home infusion provides the teaching of administration of an IV drug to the patient and/or family. Again, payers including Medicare, have strict criteria for coverage of these services. Infusion suites in a hospital or physician office have become more popular. They may be a great option for patients that do not have coverage, of their therapy at home. However, this option is less convenient and increases exposure to nosocomial infections. The primary focus of Get With the Guidelines Heart Failure is to improve the quality of patient care in patients hospitalized with heart failure. The program aims to help ensure that eligible patients are initiated on guideline-recommended therapies and receive appropriate counseling prior to hospital discharge. Of course, patient education and follow-up is essential and has been shown over and over to impact outcomes and reduce unnecessary hospitalizations in emergency room visits. Patients and their caregivers need to know how to take care of themselves. This includes lifestyle as well as medications and includes monitoring such as weight, blood pressure, perhaps telemetry. They need to know when and how to call for help or questions. They need to be monitored closely by all caregivers, no matter the site of care, and follow up with their cardiology team. There was a recent study that showed the impact of lack of follow-up on rehospitalizations. Future trends. So lots of future trends for heart failure. So LVAD, the trend is to make the devices smaller and more internal than external. There is also research into making the procedure a minimally invasive one rather than open heart surgery. There's cardiogenic stem cell therapy. Growth factors are being researched in terms of their ability to stimulate regeneration of heart tissue. Levels of apoprotein, predicted outcomes in patients with heart failure. And prevention. Prevention is key, stopping heart failure. So evaluating BNP levels for early diagnosis, leading to early interventions. All of these are hopefully to improve outcomes for our patients. This opens up to questions. Thank you for attending.
Operator?
Certainly, ladies and gentlemen, if you would like to register for a question, please press the 1 followed by the 4.